Assalamu alaikum. I am Dr.Md.Misbahul. Today I will demonstrate you the emergency fasciotomy of the leg. Uh, at first, the patient is in supine position. Then we'll apply a cuff pump to the other leg. Then we'll apply a tourniquet to the affected leg. We'll not inflate it. This is merely a precaution. Then we'll prep the leg beyond the knee and with 2% chlorhexidine. Then we'll drape the patient. Then we'll drape the patient. We'll drape. The draping has been completed. Now we'll mark out the lateral incision 2 cm lateral to the anterior border, and it should be 20 to 30 cm long. We'll make sure it is anterior to the peroneal artery perforators, which are the level of the fibula. Now we'll make incision. Then we'll mark out the medial incision 1 to 2 cm posterior to the medial tibial border, and it should be 20 to 30 cm long. Now we'll make a lateral incision along the mark through our incision mark. Now we'll identify the superficial peroneal nerve as it penetrates the crural or deep fascial distally. We'll identify the superficial peroneal nerve as it penetrates the crural or deep fascial distally. Now we clearly see the deep fascia. Now we'll incise the deep fascia anterior to the lateral intermuscular septum to enter the anterior compartment. We should be cautious that the nerve has a variable path and may enter the anterior compartment. Here there is a risk of damage to the superficial peroneal nerve. So we carefully incise the deep fascia. Then we will dissect the fascia proximally to release the anterior compartment, and we should be careful that the nerve has a variable path and may enter the anterior compartment. So we carefully incise the fascia. Then we incise the intermuscular septum, avoiding the superficial peroneal nerve behind it to enter the lateral compartment. And some surgeons recommend entering the lateral compartment directly through the deep fascia posterior to the intermuscular septum, and here there is a risk of damage to the superficial peroneal nerve. Then we'll dissect the septum proximally and distally to release the lateral compartment, avoiding the underlying nerve. Then we'll check muscular viability by assessing contractility, color, consistency, and bleeding. We'll excise any dead tissue. Then we'll check muscles of the anterior compartment, the extensor hallucis longus, extensor digitorum longus, tibialis anterior and tibialis and peroneus tertius. Here we can see clearly the tibialis anterior. This is the extensor longus, this is the peroneus tertius, and this is the extensor digitorum longus. Now we'll check the muscles of the lateral compartment, the peroneus longus and peroneus brevis. This is the peroneus longus and this is the peroneus brevis. Then we'll make a medial incision along our mark. Then we'll identify the long saphenous vein and saphenous nerve. Here you clearly see the long saphenous vein and saphenous nerve. Then we'll incise the deep fascia anterior to the long saphenous vein. We incise the deep fascia. Now we'll dissect proximally and distally to release the superficial posterior compartment. Then we will identify the flexor digitorum longus tendon and follow it up proximally. Then we will incise the fascia over flexor digitorum longus. Then we will dissect the fascia proximally under the belly of soleus to enter the posterior compartment. Then we will release soleus muscle of its origin at the posteromedial tibia. Then we will complete the dissection of the fascia into the deep posterior compartment. Then we will check muscular viability by assessing contractility, color, consistency and bleeding, and we will excise any dead tissue.